Welcome everybody. Can people hear me okay?
Yes, we can.
Lovely, thank you. I'm wondering if we make a start, or because there seems to be quite a few people here already, so I'm going to make a start. And today's session is about the Exeter couples therapy model. I don't know if anybody's had any experience so far of working with couples or using this particular model. If you just want to put your hand up if you do. Hi, Leanne.
Hello,
Thank you.
sorry, I've not got my camera because I'm just eating lunch. As soon as I'm done, I shall put my camera back on.
Lovely, thank you. So it's fair to say it's a reasonably new. Go on, Terry. So I think it's probably fair to say that it's a reasonably new model for most people, or one that's less well known. Just a couple of things about housekeeping online. If people can remember to switch the microphones off if they're not sort of speaking, it's usually quite helpful in terms of sound quality. And also, if people want to sort of make any comments as we go along, if they could raise their hand, and I'll try and attend to them as best I can as we go along. There will be space for questions afterwards, after we've sort of gone through a few slides. Hope that's okay with people. So today's bite-sized learning is on the Exeter model, which is in effect it's a hybrid model of sort of systemic and behavioural models of working with families, and I'll come to that in a little bit in terms of the history and some of the way that it's set up. Obviously, this is a very small part of it, and it's not going to cover the whole part of the model, and is meant to just give people a little bit of a flavour. Because of my professional background, I will concentrate more on some of the systemic elements of the model, particularly because I can see people like Lucy online and a couple of other people who are CBT therapists or CBT trained. So first of all, I'm going to try and get some slides up, just one moment. Can people see those slides?
Yes.
Thank you. First of all, in terms of couple therapy, a little bit more generally, NICE talk about couple therapy should be a time-limited psychological intervention derived from a model of the interactional process in relationships, where the interventions aim to help participants understand the effects of their interactions on each other as factors in the development and/or maintenance of symptoms and problems. The aim is to change the nature of the interaction so that they may develop more supportive and less conflictual relationships. And that came from a nice review of sort of what works in sort of working with couples. And NICE went back to some of the very early randomized controlled trials of behavioural family therapy from the 1970s onwards, and sort of in that way they sort of looked at it from there. Stuart, did you want to mention something?
Yeah, do you want to put it on slideshow? Because it's not showing. If you go onto slideshow, top,
yeah,
right next, there we go, and then from the beginning.
Yeah.
There. Okay.
Is that a little bit better?
That's a lot better, yeah.
The only thing is I'm there. Right. So in terms of the Exeter model itself, I think it's fair to say that it's on the more active side of family therapy approaches, which, there are several approaches within the family therapy model. And it's more active because it works directly with couples in the room, inviting them to, and also invites them to complete specific homework sessions in between, which are often demonstrated in the session itself. Although its conception was related specifically to depression in its first instance, it's also transferable into working with couples experiencing conflict or couple work more generally. I'm going to play a video, it's only about 6 minutes long, of one of the founder members of the Exeter model, Hannah Szyberski, who explains the influence and history of the model. And, you know, I think she'll probably explain it far better than I could for some of the intricate parts. So just one moment, I'll try and get that up.
My name is Mark Rivet and I'm the editor of the Journal of Family Therapy. At the 2011 Association for Family Therapy Conference, the Journal has hosted a series of podcasts. And this...
Can people hear that okay?
Yeah.
Thank you.
One of those podcasts which are available on the website for people to download and watch. Hannah Szyberski, it's a pleasure to meet you today. You are a program tutor on the Exeter Family Therapy training course. You work as a family therapist and a couples therapist in the Mood Disorders Clinic, which is a research clinic at Exeter University. And at the conference this weekend, you're going to be presenting on the model of couple work that you and Janet Rubinstein are developing and have developed in Exeter. And I understand you're writing a manual on that model. So what would you like to tell us about the basic ideas behind the model that you're trying to research and using in Exeter?
I mean, I suppose the first thing to say is that the history of the model is that Janet Rubinstein has got a long, well-established career working with couples. Invited me to join her about a year and a half ago to look at developing a model of therapy in the treatment of depression, specifically. She was interested in providing a systemic framework to what we already know to be very efficacious in couple therapy, namely behavioural work.
Yes.
So about a year and a half ago, we started developing this model of treatment, and it sits within the Mood Disorder Centre, which already had a brief to treat depression with evidence-based treatments. It's a research clinic, as you said. So we were very interested in how we could demonstrate that what we're already doing as systemic practitioners fits with what NICE guidelines are asking us to do. As per NICE guidelines 2009 identified behavioural couple therapy as effective in treatment of depression. And we really wanted to demonstrate that actually we're already doing it as systemic practitioners. The other thing to say is that I have some ambivalence about what we're doing, which I think I'm trying to make friends with, which is just the notion of manualising any kind of therapy. And I know that there's a kind of an uncomfortable often between the notion of distilling or reducing down therapy into a manual. And yet, within our profession, I think we've got to privilege and prioritise research, and this is the way to do it. So we've set about drawing on other models from couple therapy, such as Sue Johnson's work on emotional focus therapy, behavioural couple therapy, so work around communication training, John Gottman's ideas, IBCT, which is integrated couple therapy, integrated behavioural couple therapy, which is the work of Jacobson and Christensen, who saw that behavioural couple therapy was very effective, but the effects tended to wear off after about a year. So they introduced the ideas of acceptance and tolerance. And so Jones and Asen in 2000 then did his work around systemic couple therapy. So we're drawing together all these various different strands of couple therapy that are already are out there in the world. And the expert reference group last year got together and talked about competencies, systemic competencies. So these have all been things that have kind of informed our models.
What's uniquely systemic about the model of couple therapy that you are researching and developing in Exeter?
I think what's uniquely systemic, and as it happens, NICE guidelines already identifies this as being an issue, is that we're understanding depression to be an interaction.
Right.
And it's understanding the interactional nature within the couple dynamic, which we know there will be there will be behaviours that are going on within the couple relationship that are either exacerbating or maintaining depressive symptoms and or also relieving depressive symptoms. And as systemic practitioners, we know that to be the case, that we contextualise a mental health difficulty. I mean, there's another problem there in that as a family therapist, we aren't particularly interested in the notion of diagnosis. So working within a clinic that is specifically privileging diagnosis is a bit of a paradox, I think. But it's a requirement also for us to understand them, and when we see a couple, we're contextualising their depression straight away, which I think often is the first time that's ever happened for them.
So I'm going to summarise what I think I've understood, and tell me if I've got it right or wrong.
Yeah.
But what your immediate approach is that the depression is within the relationships rather than within one person, and that's how you're trying to open up the discussion and the therapy.
Yeah.
Or is that too simple?
I think it's back to both and, because I think one of the things that we would very much want to shy against is couples coming to see us and the non-identified patient feeling blamed for their partner's depression. So we're very keen not to do that. But what we're trying to do is contextualise their depression. So we'll be saying that there are things that are probably very helpful that partner is doing to alleviate symptoms. But we're understanding the depression in the context of their relationship. Does that clarify?
That very much clarifies. Thank you very much for being willing to take part in this podcast. I think you've explained your approach very well. Thank you very much.
Thanks.
Do people have any thoughts, having watched that video? Anything that they're curious about? Anything that struck them? Okay, shall we move on to the to discuss a little bit more then, if that's the case? Just get the slides back up. So some of the more pertinent parts of the sort of model, some of the more pertinent features of the model, and this is the part where the systemic and the behavioural part sort of join in many ways. But from a systemic or family therapy perspective, there's some techniques which are really well known to us, and ones that are part of our model. That would be things about reframing, the use of genograms, some internalized other interviewing. I'm going to unpack some of these things a little bit in the rest of the presentation. Circular questions, family scripts, and attachment narratives, and enactments, and some circularities, and that mixes with some of the behavioural family therapy elements of communication training, problem solving, the use of homework tasks, communication skills, and behavioural exchange. One of the sort of most important parts of the model, in a way, is the idea of circularity, and just put a very simple feedback loop up. This is one of the very early ideas of family therapy, which links to this. And the original sort of strategic family therapy idea was around a very simple feedback loop. So in this case, if we're looking at depression, you know, the husband might be trying to cheer up his wife, the wife might be becoming more depressed, and that would continue that feedback loop. And it's tempting to think that would continue and just go round and round, but what actually happens each time is it's more of a spiral. Things tend to get bigger each time. So by the time you might see a family, that pattern might be really sort of obvious. It might be very pronounced. But then as family therapy evolved, and particularly sort of in line with the model as well, the circularity became bigger, so it would encompass the whole family potentially. It would be a lot bigger than just a very simple feedback. With the simple feedback loop, couples very often argue about punctuation, which one came first. Did the husband try to cheer up his wife first and that's why she's depressed, or because she's depressed, did he try and cheer up more? And in truth, most of the time we may never know which came first, but as long as in the very early model, as long as somebody did something different, then the pattern would be broken, and people would be able to do something better. In terms of the Exeter model, what we use in terms of circularity is something called tracking very often, and the idea is to track an incident around depression that it is neatly tracked all the way around, and in preferable it sort of goes back to the beginning where it starts again, and makes it sort of very obvious. But we also track thoughts, feelings, and actions within that process as well. So a typical example might be that Greg comes home. Jane comes home, sorry, and she's been at work, and Greg's sort of the person who's depressed, and Jane might come home thinking, oh, the house is a mess, and she might be feeling quite stressed, and the action is she might be saying, well, what have you been doing all day? And Greg might be thinking, well, here we go again. He's feeling quite deflated, and he might answer, sorry, I couldn't get up today. I felt really, really awful. And we would spend a lot of time in the Exeter model going through very laboriously, each stage of the process. So we might ask Jane, when Greg has said that he can't get up today, he's been feeling awful, what were you thinking at that point? And she might say, well, I was thinking, why can't he just sort himself out? And okay, so you were thinking, why can't he sort himself out? How were you feeling at that time? Oh, I was feeling really angry with him. So it's very laborious, but this is a time limit in many ways, the Exeter model, usually up to about 10 sessions. I mean, obviously there is leeway, as the same as there is in most things, but one of the things which I think makes it a slightly briefer model, and also for some of the earlier strategic things, is a very careful working out of what actually is going on, because in working out very carefully about what's going on, it provides lots of opportunities to sort of interrupt the pattern. So we could say that when Jane is coming home, instead of asking straight away what you've been doing all day, we might say that what would it be like if she sort of didn't say anything to start with, came in and sort of had a cup of tea and then was feeling a little bit different. Or we might say to Greg, what if you weren't defensive at that point, and maybe you talked about, instead of saying I can't help it, just say I'm sorry, it's really, really difficult, and sort of teach him maybe a difficult way to communicate that distress. So it's within the very careful, very laborious exploration of what's happening that the possibilities become a little bit more. Enactment is something which is part of a structural family therapy tradition, and is very much used within the Exeter model to sort of think about that. It's a technique in which the therapist prompts a couple to reenact a conflict or other interaction. So we would invite the couple to maybe turn towards each other and maybe talk about, talk through an argument they've recently had. But just to be very clear, it's not for assessment purposes, and it's not to allow the argument to unfold in front of people so that we can see what happens, and people become sort of spiraling out of control. That's not the purpose. The purpose would be that the therapist would sit with the couple and would maybe interrupt and intervene at certain points, and maybe ask, how are you feeling at the moment? What is it that you need right now? And also, it's the role of the therapist in that situation to follow the both the process and the content. So, the couple may be talking about a specific incident, but it's maybe following the process and sort of saying, how do you think that Jane is hearing that at the moment? What is it you think Jane's hearing? There's something we use we use sometimes in family therapy called the internalized other interview, and this intervention is to try and help people to sort of start to see some of the intentionality of the other person, start to see some of the what's going on for the other person. So it's an intervention which encourages empathic connection. It asks the couple to live in the shoes of the other and answers questions as the other. It goes further than role play, as the couple member answers questions fully in the experience of being the other person rather than as an observer. And therefore, it's important that this is done in a structured manner. It's important that people are de-rolled sort of properly afterwards. But its main aim is so that couples can start to experience what's going on for the other person, what it's like for the other person, which can then lead to questions about, now that you know that this is, that when Greg is talking, he's feeling quite angry or defensive, or, how does that make a difference to your response? Active listening is something which is really, really useful, and if we're in person, not online, it might be an exercise which you might consider at this point. One person speaks just for a few sentences. It's important that the person doesn't speak too long or enter into a monologue, because it's really difficult for people to hear, particularly when people are depressed, but just generally it's difficult for people to hear something that's several sentences or a lot. The other encouraged just to listen, and then is asked to say back what they heard the original speaker say. And very often it's in that very simple way. What is it that you heard Jane say? And then it's checked out with the speaker if this is correct, and any corrections need to be made. It would then reverse, so that the speaker and listener are then reversed, so that it might be that Jane says, you're making me, I feel quite angry in this instance because I feel you're not taking me seriously. So that once that's clarified, we then would go to Greg and say, Greg, what do you think about that? And he might say, well, I'm not angry at that. I sense you're angry at that point, but that's why I'm saying that. So then we then ask Jen, what is it you heard Greg say at that point? And some other aspects of the model which are particularly important. Problem solving is a very large part of the model, and in such a way that it's a particular type of problem solving. People would define what the problem is. There would be an opportunity for the couple to brainstorm potential solutions, and then maybe look to evaluate the pros and cons of them, and then maybe negotiating, even to the point of contracting around some of these problem solving, some of these potential solutions. Blame reduction, using I statements rather than they statements. They're doing this, I feel like this when this happens. Creating safe spaces, often by contracting, by making agreements as to what's okay and what isn't, having some ground rules for the sessions. Emotional regulation, which might be about generating and agreeing timeouts, using descriptions rather than evaluations, maybe teaching some self-soothing, some grounding exercises, some meditation techniques, tracking emotional patterns of partners, and sort of comment on the emotional pattern rather than the immediacy of it, and also some self-soothing techniques. The Exeter model uses some specific outcome measures. It uses the Score 15 family therapy outcome measure. The next one's a tricky one because of rights to use this. It is recommended that the Beck's depression inventory is also used as an outcome measure, and it's recommended that it's used with both partners within the couple, because it's recognised that depression can affect the whole couple rather than just one member of it. So we would often do that. We would use the outcome measures for both partners. And I think what we came up with bear in mind this was quite a few years ago when I did this training, is we thought about using the HAD scale if we weren't allowed to use the Beck's depression inventory. And finally, some about the availability in the trust. Unfortunately, at the moment, there is only myself that's trained in the Exeter couple therapy. The trust did train a group of people, but you know, people left and people didn't sort of carry on in roles. And at the moment, the intervention is available only in the adult inpatient area at present. So that's in the Bitesize. That's the sort of Exeter couple therapy model. So I'd be really interested to hear if people have any questions or any thoughts at this point.
Hi, Michael.
Hi,
Sorry.
Lucy.
You
You all
okay?
right? Yeah,
Yes.
you.
Not bad, thanks. I was just wondering why you were thinking around using a HADS over a BDI. I know the licensing on a BDI, but I was just wondering why you thought with the HADS.
The first choice would be the BDI. It was the licensing, that was all, and I think that's why at the time there was some debate a few years ago about the licensing. That's why we ended up with the HAD instead of the BDI, but it's recommended the BDI because it's a far better outcome measure.
Because that one's for depression, isn't it, the BDI? And I was just
Yeah,
the HAD
and
same one.
yeah, anxiety and depression, isn't it? The HAD,
Okay.
yeah.
Okay.
Thank you, Michael. That was really interesting. I was just wondering what sort of outcomes you're having, you know, with your inpatient group.
We had some very good outcomes, actually. Most of the people showed improvement, and most of the sessions were oh gosh, I would say that they were between 2 and 8 in length. I mean, it's been sort of quite an ongoing thing, and some of the we hold stats for all of the family therapy in the inpatient setting, rather than just for the Exeter model. But they were good, particularly the score outcome measures were good. I'm guessing that's probably because they were related to the relational aspects of the couple therapy work itself. So most of them, I think, pretty much all showed some improvement, apart from, I think there were 2 out of the group of about 15 who didn't, and who really struggled to it. And in their case, I think it was also related to the stage they're at in their mental health as well. And you know, it was quite a big ask for some of them. And so something I did notice, Joanna, as well, is that it was quite tricky in terms of, I thought we needed, I found myself leaning a lot on the emotional regulation part of the work in the inpatient setting, and I found that was a bigger part than some of my colleagues who were doing it in different areas, because we were having supervision post course. So
Yes, there might be an option to do some collaborative working with the ward, or with people who are working on that. You know, you could have that running alongside your couple therapy, which might make it more useful to you.
yeah, but particularly now, we didn't have those options before, and I think the tricky part is that it's less defined in the work now. It was the early stages of when many people were trained that we got the best statistics. Really, we have less statistics moving forward because the work has changed a little bit as well. But I agree. I think the emotional regulation would be really well done with other colleagues, and to join as part of joint working.
Thank you.
Thanks. Any other thoughts or questions?
Me again, sorry.
No, you're right. Go for it.
I really like the look of the model and the different aspects of it, but I was just wondering, have you found any limitations to using it in practice?
Not so much limitations. I think some of the limitations are around sort of couples' expectations of what the work will look like. I think it has taken quite a bit of explanation for couples, and quite a bit of sort of saying, you know, how this will be useful for them. And I think there's something about turning together and looking, which is difficult for some couples as well, in terms of the enactments, and sometimes that's needed to be modified, particularly where there's cases of low self-esteem, a person's had previous experience of abuse. It's quite hard to look and at each other in that way. So there are elements which need to be changed a little bit, really. And I think, same as any model, it's to do it in its purest form in an inpatient setting. is a challenge, and sometimes it's about having aspects of the model and then using those, and then that being in a way good enough.
Well, thank you.
Thanks. Nick.
Hi. Yeah, I was just thinking, following on from that last question, I've not had the training in the Exeter model of, formally. Obviously, I've come across it as a family therapist. But is the model itself, is it like a manual approach? Is it like set out to do things in a specific order, or is it more to go with the flow with, you're using those skills and techniques, methods and techniques within the model, but you do it as in what the parents, the couples, see I'm working, I work with parents and children. Yeah, so I'm just curious about how you deliver the model.
Yeah, I mean it's manualized, and I would say there are certain aspects it's useful to concentrate on first. So one of the ones I think is very useful to concentrate on first is the tracking, because then you know what the issue is. You're then able to build the rest of the work around it. But in truth, it's manualized, but not necessarily in a certain order, because each couple is different. So some aspects might take precedence over others. But I think the tracking bit is important first, because it is a bit like the formulation then of what's going on, and then you can base the rest of the treatment around it. But it may be that issues come up about sort of emotional regulation first. It may be that issues come up again around couples understanding each other first. So it tends to be led in terms of what the need is at that time with the couple. So you might start tracking, and it might be then really important to start talking about going to a session about active listening. What is it you heard your wife say at that point? What is it you heard your partner say at that point? So it might be important then to move it around a bit, Nick. So and people, I think sometimes manualized approaches can work very well in the sequence which they're put. I think for most manualized approaches there is an element of mixing and matching in terms of your order, particularly. I don't know if other people find that in different models.
Thanks, Michael.
Thank you. Any other thoughts or questions?
Hi, Michael. It's Laura.
Hi, Laura.
Hiya. I work in IAPT, and I don't work with multiple people at the same time in terms of the room. But say I've got a patient at the minute. I'm just thinking about the fact that a lot of their anxiety presentation is actually related with the fact they're in a very unhappy marriage, and have been for 40 plus years, and they're quite aware of that. They don't want to change. Do you know what I mean? Like their circumstances, and obviously we all know that's that's obviously what they need to do, but that's not what they want to do. So we're going to work around that, and they're presenting. Then they've moved on to kind of like developing like a generalized anxiety disorder. Do you think I could use any of this model, not necessarily directly, but maybe as a, have you tried doing this with your husband kind of thing? In a problem solving kind of, if their communication, or if they will need to like improve assertiveness or something. Or would you just say, because we have recommended that they go to couple therapy, but that's not an option.
Yeah, and I think with a lot of that's not an unusual case, Laura. I wouldn't have thought that sometimes it's a bit of a crossroads. Do you try and encourage the person a bit more and say this is definitely about couples or family, or do you then say, actually, if that's not on the agenda, then we'll go with the individual, or we'll think about what's possible and what isn't in that situation. There are some elements, I guess, things like you can ask people to think about if they want to do some problem solving with the partner. You can ask if they do maybe a little bit of a brainstorm around what they could do differently, or the other parts. But there are certain parts of the Exeter model where it would be hard to do, because they are about couples in the room and about about people in the room. And the other thing, of course, is it is a training thing. So, you know, most people who go on the Exeter model training, what's really nice is we trained family therapists and CBT therapists alongside each other because of the different parts that the model comes from. So that's nice. But it is, you know, like learning a skill in a way that there is a training course attached to it with the assumption that people are sort of trained in one modality out of the two. But so it is possible to do some of the things. Same with anything, it is possible to pick parts out. There's some things which are useful, but it's you know, I'm guessing it would be a challenge as to which ones you could include. But if there are elements of problem solving, you know, some of those things are universal. They're not necessarily part of just belonging to a model, are they? So, you know, those things are really useful. You know, things like timeouts are really useful. People deferring their reactions and coming back when they're feeling calmer is an idea which sits within models, but equally so is quite well-known way of coping with feelings, I guess.
Yeah, thank you.
Thank you.
Thanks.
Leanne, did you have your hand up, or because I've got Rebecca as the next one?
I did, but Rebecca can go next. That's fine. I can wait.
Lovely. Hi, Rebecca.
Thank you. Hi, Michael. Hi, everyone. I guess just following on from what Laura you were saying, what you were describing, Michael, in terms of the model, it really reminds me of a CBT intervention called CBAS, which is cognitive behavioural I can't say it, analysis of psychotherapy, and it's an intervention for people with depression, and in terms of their relationships, it's more of an interpersonal slant on it compared to other CBT therapies, and it's all about kind of unpicking the meaning of arguments and kind of people storming off and actually what's the hidden meaning under that, and kind of what assumptions are you making within that like interaction. I mean, I only had a taster of it, but Laura, following on from your question, I'm wondering if that might be helpful for your individual in terms of an IAPT provision.
Yeah, I'll definitely look into it. I've not used that myself before. Is there a particular document or anything that you?
I went on some training years and years ago. I went on some training a few years ago. There's a guy called, I can't remember what his name was, from Barnsley that was kind of spearheading it. But if you want, I'll contact you and send you some information so you can check it out.
Yeah, please. Yeah, I think we get this. Obviously, you know, it's the patient's goals for treatment, isn't it? But it's managing their expectations on recovery when obviously their circumstances remain stressful. And I think what definitely changed for this person is that the way that they were managing the unhappy marriage before has now reduced because their partner's retired and is more in their space. And so there's less kind of distractions or ability to separate and things like that. So it's just trying to build, you know, see if they can, it's like a big adjustment as well, but they're just not willing to alter, you know, they're in the 60s, nearly 70s, and they kind of lived this life for a long time, and the alternative just seems too scary right now.
But there's nothing to say you can't revisit with families and review that on a reasonably regular basis. And I'm guessing the important thing is to be honest and say, you know, we think this part, and you know, it might limit your opportunities for recovery otherwise. But ultimately it's a collaborative thing. You know, people aren't mandated to work unless they're under a section of the Mental Health Act. So it's a lot of things are about negotiation, aren't they, and about sort of thinking. But and the other thing, Rebecca, I was just thinking that lots of models do cross over, and you know, in a way it's a strength that we share lots of things. We might describe them differently ultimately, but you know, there are possibly it's come up in several models because it's good and it works for all we know. So yeah. I've not heard of that, so I'll have a look up at that one.
I'll put some information on the chat if people are interested, just to have a look. I mean, it's been a while since I had any dealings with it, but I can remember going away from the training thinking, yeah, that's great. I can really kind of get my teeth into that and make use of it, particularly in terms of the assumptions people make when they are interacting with their spouse or partner. Yeah, just kind of pick it up, similar to the Exeter model in terms of kind of unpicking thoughts, feelings, actions, and kind of and what their assumptions are, and what that conversation means to them in that moment.
Yeah. Yeah, it sounds like that's more of a sort of, did you say psychotherapy by background underneath, or?
It's a CBT. It's kind of BABCP are kind of promoting,
Yeah.
or we're promoting it. So yeah, I think it's part of a strand of CBT.
Yeah, okay. Lovely, thank you. Any other thoughts or questions?
I suppose similar to Nick, kind of my experience of it has been like a training session at university on our master's course. And I know we're very well versed in looking for relationship difficulties, but I'm just wondering if you have a criteria for those that might access the Exeter model. Working in CAMS, I can see that it'd be really helpful for maybe quite a few of our families. And I'm thinking about how we might introduce that to couples when they bring their children. Quite often they might think that it's the young person that needs to be doing the work. So I'm also thinking about how we might introduce that. But I'm just wondering if you have a criteria.
I guess if the criteria very often is very similar to the one which would be for working with adults in the inpatient setting as well, it is that, you know, do people think that the relationship in some ways is maintaining the difficulties that the person has. I'm not a great believer in causation in that way, that you know, family dynamics cause mental illness. I'm sure sometimes they do contribute, but you know, whether they contribute or maintain, it'd be whether there's that element to it, and whether that gets in the way of discharge, or whether that gets in the way of people's improvement, or whether that leads to repeated admissions or repeated relapses would be some of the things I would be looking at, and also whether it's based in the family and people think in the couple relationship, and whether people think I know it's very obvious, Leanne, but it's that, you know, if people don't think that's related to the couple, then I wouldn't necessarily work with it, even if you know, you know, the couple were saying, well, we think, well, I guess if the couple was saying we think it is and professionals not, I might look at it. But if nobody was saying it's related to the couples, then I wouldn't obviously come in and say, oh, I think you should do it.
Yeah. I suppose a broader issue might be, will there be any future training, given that you're the only person in the trust that is trained?
I would hope so, because it's something that can potentially span family therapy and CBT, and in that way I think it would be quite a rich sort of resource within the trust, and a rich resource of sort of people coming from different backgrounds. I would love to be working, I don't mean this in a bad way for you and Nick, I would love to be working with somebody CBT trained, because they would pick parts of the model out which I might not, and it would be really useful learning experience. Yeah.
No, absolutely, I agree with you. Thank you.
Any other thoughts or questions? Okay. Thank you very much, everybody, for coming today. I hope you found something that was useful or interested in today's, and it's been really nice to hear people's thoughts and questions. It's a very valuable opportunity to hear feedback on the model, because it does make you think a little bit, and make you think about other ways which it might be useful, or other things you'd not thought about. So thank you very much, everybody, and I hope to see you in working wise in other settings.
Thank you.
Thanks.
Thank you. Bye. Bye,
Bye.
everyone.
Bye.
Thank you. Cheers.
Bye.
Thank you. Bye. Bye.